So if people are keen to be start assessors or already are start assessors, they've asked me just to highlight the next start dates, partly because we've had some challenges with the start assessment. So if anyone is interested in being a start assessor, then Lizzie, I think, will probably be putting some information about that in the chat a little bit later on about it, or you can obviously get in contact with the college about it. Last session we discussed Progress Plus, and I'm hopeful that most of you have looked at that information, seen the webinar that's on the Royal College website, or have been looking at the college about Progress Plus, because it's not that far away now. But I wanted just to highlight a few updates that we've got around Progress Plus, which might help you as a supervisor with supporting your trainees. So firstly, there is a Progress Plus and Me document that's been updated October time, and that's really for trainees about what's going to happen to them per level. But I think it's a really helpful document. Again, Lizzie's putting it in the chat. A really helpful document to help you with the trainees, depending on what level they are, that you can read, so that you kind of understand what they're going through and what's going to happen over the when we change to Progress Plus next August, September time. The curriculums are there on the website. They've been there for a while, but if you haven't had a chance to look at them, I think it's probably worth having a look, because obviously there are not many differences, but just getting your head around the different levels of the core and the subspecialty and where things fit, I think is really useful to support your trainees from now, because they can start to look at those curriculum and evidence things within their portfolio for when Progress Plus does come in. And then there is an excellent webinar. It's not very long, only 18 minutes long, from Catherine Chadwick, VP for Education, Training and Assessment, and also Kay, who is Workforce Lead, looking at the impact of Progress Plus on those trainees from ST3 to 5. Also thinking about the impact on subspecialty training and what trainees really need to know. There's a bit about less than full-time working on there, trainees going out of programme and the implication of that and Progress Plus, as well as academic changes and impact for academic trainees. So I think it's a really valuable short video for you guys. And again, I think I've put a QR code to link to it in my presentation, but also Lizzie's put it in the chat as well, which is handy. But couple of other things. So at the moment, depending on your region, so I know that some regions ST3 are already on the middle grade rota, but for a large number of areas, that's not the case. And so it's just thinking this year about those ST3s and getting them as supervisors, supporting them with that middle grade readiness. Because obviously when we move to Progress Plus, they'll go to ST4 and in the core, and will be in their core paediatrics, and then the following year they'll move up into subspecialty. So they will have a little bit less, obviously a year less at sort of middle grade working. So we're thinking now is the time to start supporting your trainees if you have ST3s in that middle grade working, and getting them to act up and doing all those middle grade to support them a little bit. And then finally, last thing is that if anyone is interested in supporting Progress Plus and being a Progress Plus ambassador, then we'd love to get you to contact us so that we can use your enthusiasm with regards to Progress Plus in your area. So if you are interested, then do let myself, Lizzie Allen know, or email the training and quality team about it, and we will get back in touch. And I think that's all I'm going to say. Actually, I've got one more slide, I think. So this is what we're going to the programme outline today. So as I mentioned, Alice, who I'm going to introduce now. So she's an ST7, working as in London as an academic trainee 50% of the time, and a paediatrician 50% of the time. And she's going to come and talk to us about supporting trainees with the research domain and supervising academic and non-academic trainees. And I'm really thankful for her to come today to do this presentation. Then we're going to have a little bit of a break, And then, as we said, the Officer for Health Improvement, Dr Helen Stewart, is going to come and talk to us about health promotion.
Hi everyone, my name's Alice. I'm an academic trainee at ST7 level. I am a general trainee with an academic interest, which I think is quite a rare thing, and I will kind of advocate for that a little bit through this talk. I'm going to assume that there's a mix of consultants in the audience, some with some academic background and some with some not. And I'm really sorry if I'm telling you anything that you already know. I hope I'll be able to leave a chunk of time at the end for any questions and some sharing of examples. So my brief for this talk was fairly broad. I think we need to look at the Progress Plus curriculum and specifically the research domain. So I'll outline a few of the differences on that. I've been asked to talk about, as an educational supervisor, how to supervise academic trainees, how to supervise non-academic trainees, and how to maybe promote research within your department. So interactions between the academic and the non-academic trainees. I've done a reasonable amount of preparation in terms of canvassing opinions from various people. I know quite a lot of academic trainees, but I've also just spoken to a fair few non-academic trainees. So I hope I'll illustrate this with a few personal examples and tips for educational supervisors towards the end. So, outline of my talk, I'm going to give some background around the state of research in paediatrics. I think there's a lot of things we do know, but actually I think it's useful to take an overview of what's happened in the last decade or so and which direction we're trying to move. I'll talk about academic training in paediatrics and what it looks like, or often what it doesn't look like. And in researching this talk, a couple of people came to me to talk about women in academic paediatrics and some of the problems. And then when I did a little bit of reading, I was quite shocked by some of the statistics. And I think this probably isn't talked about enough. So I'm going to talk briefly about that. I'll come on to the life of an academic trainee, the new key capabilities in the Progress Plus curriculum. I'll signpost to some resources, and then I'll end with some tips for educational supervisors. So I hope that there's a consensus that we know pretty much that the evidence base for much of what we do in paediatrics is pretty weak. Now, historically, there was a reluctance to include children in research that was probably appropriate, and that was a way of protecting them from unethical research or from experimental drugs, etc. The problem is that attitude is very out of date now, and ethically we're not serving our patients well, but a lot of those historical constraints still exist, and it's still very challenging, or much more challenging, to undertake research with children than it is with adults. But this is a rights of the child concern, and it is an ethical problem when we are just translating adult studies, adult treatments onto our paediatric population, despite all the differences that we know about in terms of children's physiology, etc. So the international situation is shown here. So this graph shows the tall blue bars is the total number of studies happening, and the shorter bars are the number of studies happening in infants, children, and young people. So internationally, studies on children and young people make up about 15% of the total studies. In the UK, the situation is actually even worse. So this statistic might be a little bit out of date, but going back about 10 years, only approximately 5% of the UK annual research expenditure was on paediatric research, which is a really big problem. And there's also a lack of guidance. So only 20% of NICE guidance is actually applicable to children. The RCPCH in 2012 published this Turning the Tide report, which was looking at child health research in the UK, and it makes for some really bleak reading, to be honest. Basically, the conclusion was capacity for child health was critically low, and so there were a number of issues. In terms of the workforce, the number of paediatric professors and academic paediatric consultants had been falling, and a lot of those positions were held by people kind of nearing retirement age. The percentage of new consultants with higher degrees had been progressively falling, and only a minority of paediatric trainees at that time felt that they were trained in basic research methodology and research governance. So, for example, could you consent a child and a family for taking part in a randomized controlled trial? This report also commented that children and parents advocacy was weak and insufficient, and this is something I'll come on to because this is a really important concept in research. There was also the conclusion that paediatric representation on major research boards is weak. Following this report, in the last decade, there have been some improvements, specifically the formation of networks and taking advantage of opportunities to take advantage of technology, to take advantage of electronic health records, and to decide sort of as a network what research questions need answering. So I think there have been improvements. In terms of paediatric academic capacity, things haven't shifted that much. Positions have been sort of stable-ish, but it's still not huge. And unfortunately, we've now left the European Union, and the effect of that on basically bureaucracy and red tape, I would anticipate is going to make the research environment even more challenging. I've put this infographic on the right, which is looking at research and us. So this is about the concept of patient and public involvement and engagement. So the idea is nowadays that we should not be undertaking research, and not just research, to be honest, really anything. So service development, even evaluation, without talking to either the young people directly, if that's possible, or to their families, their carers, and other interested stakeholders. So this idea of nothing for me without me. I won't read all the way through this charter, but I'll come on to, this is the NIHR involved definition of patient and public involvement or engagement. So this is actively working in partnership with patients and members of the public to plan, manage, design, and carry out research. So research being carried out with or by members of the public rather than to, about, or for them. So I think the problem is historically there was a lot of arrogance that we as doctors, because we've been working with the patient population for decades, might know exactly what they wanted. And actually, when you go and ask the young people, you often get really different responses. The reason I'm putting this in is because I think when it comes to peds, it's often not quite so obvious how to do this. So there are various young people's forums, and I've put some of the names of them up here. So there are young persons advisory groups across the UK. There's the RCPCH and US and the NHS Youth Forum, but these would mostly be teenagers, for example. When you're dealing with research or service development for younger children and maybe for children with disabilities, you need to think a bit more laterally. So then it's about talking to the carers, talking to the stakeholders, maybe forming partnerships with charities who work with that patient group would be a way of doing that. One of the reasons this is important is if any trainees you're supervising want to undertake research, they need to be thinking about patient and public involvement in the very, very early stages of that. And when you've got protected research time, you can build up partnerships and do this over time. But when you don't have that time, it can be a bit more challenging. But patient and public involvement doesn't need ethics approval usually, and it's something you can do quite informally, even within your department. So just asking the opinions or writing questionnaires, asking for feedback from patients within your department. Sorry. Okay, I said I'd mention women in academic paediatrics. I myself have just come back from maternity leave. And one of the experiences I had prior to going on maternity leave was being told initially that I would lose the remainder of my academic time because my academic contract was due to finish towards the end of my maternity leave. And a number of people advocated for me really strongly, and I've ended up getting that time back. But I found it interesting that despite the fact that I'm an academic trainee with UCL, who have a Athena Swan Gold Award, and in paediatrics, we're a sort of very female-heavy specialty, that it would still be such a challenge with such obvious barriers to being a woman in paediatrics. And when I was asking in preparation for this talk, quite a number of trainees came forward with similar stories or to say how they felt penalised. Looking up some of the statistics, so these statistics on the slide are from a paper in 2015. So on average, men in paediatrics authored almost twice as many publications as women. Men in paediatrics are much more likely to hold PAs for research, and women are less likely to hold any honorary or primary academic contract, to have authored a publication or supervised a PhD student. I know we're not going to be able to fix all of this, but I think we should be angry about this. If we're in a predominantly female specialty and yet the higher positions and the research environment is not reflecting that, then there is structural misogyny and we need to address this. I think just being aware of this is probably the first step, but I think we also shouldn't be accepting it if we're told, oh yeah, it's not really anyone's fault, but the way the systems interact means that you're penalised as a woman. I think that's not acceptable, and I hope you agree with me. Okay, what academic training looks like. So in 2006, the NIHR created integrated academic training, which are the academic foundation programs, academic clinical fellowships, academic clinical lectureships, so ACFs, ACLs, etc. Broadly speaking, this scheme has been a big success. So unsurprisingly, medics are often very bright and have a lot of academic capabilities, but going back in the past as a trainee, you pretty much had to choose between only doing clinical work or dropping out of clinical work and being an academic. And now this supported integrated training has been a big success. However, you're often shown diagrams like this, which say out of medical school, you should do an academic foundation program. You should then go into an academic clinical fellowship. You should then come out and do a PhD, then go into a clinical lectureship. I would say it's great that those opportunities are there, but I'm not exaggerating when I say I do not know a single person who has taken this conventional path through academic training. And I think the important thing to understand is there are multiple other options. So trainees in your department might have an academic background or be hoping to apply for higher funding, but currently be full-time clinical. There are standalone research positions like mine, which is a little bit unusual and doesn't fit with any national scheme. There are year-long fellowships. People might be in an OOP-R, they might be just out of programme, and there are lots of associations between the academic pathway and global health, so quite a lot of people would work overseas at various times. And I know lots of trainees who have ended up going less than full time so as to do their research in essentially their free time. I mean, I hope we shouldn't always be in this situation, but that's often a short-term fix if you're kind of engaged in a very long research project and you lose your academic time. That's often the way of carrying it on. So I think understanding that there is flexibility about these things. Okay. I wanted to talk about some of the perks of being an academic trainee, and I don't want it to come across that I'm just complaining and saying this is so difficult. I'm very well aware, having been a non-academic trainee, of all the pressures on us as trainees, and we have a high attrition rate, incredibly high workloads. So the benefits of going into the formal academic training: you get protected time, so you're paid your full salary, and essentially you're left free to seek out a supervisor to choose your own projects. Tends to be associated with good locations. You're quite often in teaching hospitals, and quite often you don't have to move locations every 6 months or whatever, which is just a lot easier, I think, than a lot of the ordinary clinical training positions. There's opportunities to do higher degrees, and they're often funded or at least partially funded. I had my MSc fully funded, and I'm having a doctorate 50% funded by UCL, which is a massive opportunity. There are opportunities for travel and working overseas with those global health networks. You get to attend a lot of conferences. You often get invited to give talks. You get a lot of additional training. And I hope why it actually matters is in the long run, you actually see a link between the child in front of you and the questions you're asking about the child in front of you and the academic work you're doing. My own work is quite involved in vulnerable populations, complex safeguarding, and so quite often we're writing things with a view to trying to influence policy. And I personally find that really rewarding, and I think that's one of the ways you can make a difference on a big scale. So, as I said, I've canvassed the opinion of various other academic trainees, and I've tried to do a bit of a thematic analysis around some of the challenges that are faced. I am aware that as educational supervisors, you often can't fix these things, and I don't think we're expecting them to be fixed, but I think often to have a little bit of insight into what people might be wrestling with. So quite a lot of trainees I talked to said there's a really big challenge with balancing your clinical and academic life, and sometimes also balancing childcare or working less than full time. So There are lots of different ways in which academic positions are broken up. Sometimes it's a solid chunk of like 9 months of protected time and then you're back in full-time clinical. Some people divide up the weeks, for example. Nothing's ideal. Almost everyone I spoke to said they often feel that they still have clinical responsibilities on their academic days. You know, your clinic admin, or you're still getting called about things, you feel the need, you have to chase stuff up. And the academic deadlines don't stop and they don't really respect whatever else is happening. So one example somebody gave me is so frequently you've got a 3-week window in which you have to support you have to submit a grant proposal, you have to apply for a fellowship, you can't control the timing, but it coincides with you being on a block of nights or whatever. We know that these problems aren't fixable, but just have some understanding that often you're trying to juggle multiple things and that can be extremely stressful. Quite a lot of, particularly the junior academic trainees I spoke to, talked about feeling isolated. So often you don't rotate around jobs in the same way as your peers. And the way the protected time works mean you might often come into training, for example, halfway through a job and have very little warning about where you're going to be placed clinically. Having just recently come back from maternity leave, I know about the support budget, which can be used as well for a trainee returning from academic time, returning from a PhD, for example, if they feel inexperienced clinically, and that's one of the ways we can ameliorate that. I also think, I'm not sure exactly how it works, but I talked to a lot of people who said, oh, I turned up halfway through a rotation and nobody knew I was arriving. I think it is worth thinking, are there any academic trainees coming into your department and are they going to arrive at a different part during the rotation? Because often that can end up with those trainees feeling quite isolated and penalised. Again, I know these problems are wider than just academics, but everyone I talk to has not been paid their salary for at least 1 month. The strange way the funding streams work, which is often if you go into protected time, it's actually your last hospital who are still supposed to pay your paycheck, and often you get taken off payroll for various reasons. There are lots of issues with not being able to access study leave or study budget within the hospital you're working because your funding stream comes from elsewhere. And a few people talked about coming late to a rotation and not having been included in any of the rota emails, so they end up working Christmas or not having any choice about their annual leave. Again, just a little bit of understanding that this might be the case and trying to support people through that. Lots of people commented, and my own experience is the endless paperwork. If you'll humour me, I'll just give my own example. My UCL fellowship position means I am an employee of UCL, and as such I have regular appraisals, I have to upload development plans, I have to upload meetings, I have to show evidence of my progression. I'm a UCL doctorate student, which comes with its own e-log. You have to upload meetings, you have to have meetings with various tutors throughout the year, everything has to work to a schedule, you have to evidence your progress against a learning framework. As well as that, I'm an ordinary paediatric trainee with all the clinical requirements of ePortfolio. As well as that, there is a separate RCPCH ePortfolio requirement for academic trainees, where you have to fill in another set of forms, which get viewed by somebody separate from your research who might not know anything about it. As well as that, that's mandatory e-learning for UCL and for the hospital I work in. And I've also held 2 honorary contracts additionally for the sake of my research, which have their own mandatory e-learning, which has to be updated all the time. You can see that this workload on its own can become absolutely enormous before you try and actually undertake any research. And I think what's really frustrating, and what brings me on to the next point, is when you're then, when you fail to fill in the form, or it turns out the form you filled in was from last year and not this year, and then the response at ARCP is, we are extremely disappointed with the behaviour of this immature trainee. I think just a little bit of understanding that we're not necessarily able to keep on top of all this stuff, and it would be almost impossible to do so. I hope in future there will be a little bit more streamlining between all these different requirements. One of the trainees I talked to said, yeah, I use copy and paste quite a lot when it gets to the end of the year. Okay, Coming on to the Progress Plus curriculum. So what I've put up here are the key capabilities in the research domain. So on the left, it's the ones for core trainees, and on the right, it's the one for higher trainees. So I think broadly speaking, you can divide these into key capabilities that are much more about understanding research. So that's developing your research methodology skills. So for example, through things like Journal Club, understanding the hierarchy of evidence, understanding critical appraisal and critical appraisal checklists. And I think all of this is quite reasonable, and I hope we've been doing some of this stuff in the past. So that's things. Did anyone have a question? Sorry, I can't see anyone. So this is things like interprets research results, implements an evidence-based approach, constructively analyzes management, maintains good GCP. The one on the right explains the purpose of research trials to children and young people. I think this is really important. And so this would be about communicating research, which is a different skill set on its own, I think. So putting something into lay language and conveying the central message. And I think that's something we can all be practicing all the time. And when you take consent, or when you propose to a child, to their family, that they might want to join a research trial, for example, that's what you're doing. Now, the more challenging bit, I think, of meeting these research domains is when it implies that the trainees are going to be undertaking their own research. So on the left, you've got carries out a systematic literature review. This is slightly odd phrasing. I mean, a systematic review means something very thorough, and I don't think we would expect core trainees to be undertaking a systematic review. I think doing a literature review in a systematic fashion. So just understanding a bit about the, PubMed, Cochrane, what resources are out there, looking at review articles, going to the meta-analysis or the systematic review to answer a question rather than looking at individual studies. That would be how I would interpret that. So coming down, participate in research-related activities such as national projects, journal clubs, publications and presentations. I think all trainees should have the opportunity to be part of Journal Club. And publications and presentations, I think, can be a bit easier than we think they are. I think a lot of this comes down to what we think research has to look like. And it doesn't necessarily need to be a trainee on their own collecting original data, and particularly not writing a protocol, going through ethics approval and undertaking their own study. I think that would almost never happen. But I think there are lots of other things we can do which probably fall under that umbrella of research. So a couple of suggestions from my perspective. If you are collecting original data, that could well be things like audit, service evaluation, quality improvement projects. It could just be within your department. And quite often those are amenable to a presentation, to a publication. I think it's worth learning as educational supervisors when the big deadlines are. For example, the abstract submission deadline for the RCPCH conference. The advantage to submitting an abstract to that is that if it's accepted, as well as getting a presentation, your trainee would also get that abstract published. And so you can end up ticking quite a lot of boxes all at once. Patient and public involvement and engagement, as I talked about previously, there's actually quite a lot of funding pots available for this, and various schemes within hospitals, within the NHS, within universities to promote this. And actually undertaking a patient and public involvement project, I think, would be a really valuable thing that would probably meet a lot of those research domain requirements. Contributing to guidelines, writing guidelines. I think this is a way of influencing policy that can be even more important than doing your original research. And really to write a set of guidelines, you should be familiar with all the existing research. So that does involve a literature review, which is in itself an independent piece of work that can reach a lot of those criteria. I think if we think a little bit more laterally and move away from those more conventional ideas of what research has to look like, there are lots and lots of opportunities. Okay, coming on to which resources are available. To be honest, I was a bit overwhelmed and so many people were suggesting them. I'm sure I've missed out some really important resources here, but I've tried to signpost to some of the important ones. So there are trainee research networks. There's the RCPCH Trainee Research Network, and they have a list of links to regional trainee research networks. I don't think you need to be an academic trainee to engage with these things. Just if you're interested in researching, want to find out what opportunities are available, that's something you can pursue. There's the Academic Paediatrics Association, who promote academic paediatrics. They have their own conferences, they have their own website set of resources. On the RCPCH website, there's a list of research funding opportunities. I mean, it's absolutely huge. It can actually feel a bit overwhelming, but there are lots of things there. There's something called the Academic Toolkit, which has been developed by academic trainees, and that's quite easy to Google. There are quite interesting personal stories on there. Lots of them are my unconventional route into academia, but as I said, I think almost everyone ends up taking an unconventional route. There are some resources on the Academic Toolkit about how to structure your time with all the different parts of planning a project, writing a protocol, ethics, publication. It is very valuable, but I would also say it can feel very overwhelming. And I say this as an academic registrar undertaking a doctorate. So goodness knows how it feels if you're, an F2 looking at that thinking, oh goodness, do I need to do all of this? So I think it's valuable and it's there, but that's not what your research needs to look like. The NIHR have a number of resources, but there's something called NIHR Learn. And part of the reason I'm putting this up here is there are quite a lot of e-learning courses and links to other learning, including GCP, which I'm not the biggest fan of myself, and it's quite a lot of red tape, but it's a really big box to tick in terms of research governance and your understanding of these kind of things. And it will teach you how you should take consent, how to understand the process of trials, for example, happening in your hospital. There's something called the Associate PI scheme that has come in recently from NIHR. One of the things I failed to do in preparing for this talk is find any other trainees who are undertaking this. So the principle of this is if there is an NIHR funded study happening in your hospital that has a local PI, you as a trainee can sign up for the Associate PI scheme as part of that study or trial. You're involved in it, you go to management meetings, you have a series of learning, and then at the end of the 6 months, you get a certificate. And this is supposed to be a way of sort of promoting your skill set so that potentially you could become a principal investigator in your own right in future. I think it's a really valuable scheme, but I think it's probably not happening on the ground very often. It's probably worth academic consultants having a look and trying to work out what's happening in their own hospitals, because having looked through the website myself, it is quite difficult to navigate, and it's very difficult to figure out what might be happening in your own hospital and what you might be eligible for. So I think if there are any academic consultants listening, this is something that you could have a look at within your own units. The London School of Paediatrics Trainees Committee have an academic subgroup, and I wanted to signpost to this specifically because they have some really excellent resources on there. So there is a Pan-London academic mentoring scheme, and I think sometimes if trainees are already on the academic pathway but very early on, or just if they want to, it can be really helpful to link them up with some kind of mentoring system so that they can understand a little bit about what their career might look like. There's ACF interview prep, there's research evenings, there's this Reach network that you can see on the top left, who signpost quite a lot of different things. And they also have a protocol for setting up a journal club in your hospital if there isn't one already in place. So really useful resources on the website. Okay. So I wanted to come on to some tips for educational supervisors. So these are mostly what people have shared with me as really good examples of things that have been really helpful to them. I would say that it was an educational supervisor that sent me into the academic pathway. I think when educational supervisors are good, they can really change the course of your career, and it can be incredibly valuable. I don't think I've ever had a bad educational supervisor, but I've had some who were truly excellent. So some tips from a few different trainees I talked to. So before the start of the job, if possible, match trainees to their educational supervisor by interest. And this doesn't just need to be academic or non-academic, but in a couple of hospitals I've worked, an email went out before the start of the job saying, what's your area of interest? Let us know and we'll try and match you with an appropriate supervisor. If there are academic trainees, it's really helpful to match them with academic consultants, but we realise that's not always going to be possible. If you are an academic trainee and you have your first meeting with an educational supervisor, somebody commented that just giving the opportunity for the trainee to explain their research interests in that first meeting, she said, even just 10 minutes makes you feel valued, and I understand what she means. We talked about this previously, but thinking about where the trainee has just come from and whether they need any extra support, because it may be that they've been out of clinical training for much longer or haven't done, for example, a neonates job or an intensive care job for much longer than another trainee, and whether they need extra support with that. For academic trainees, but really for any trainees, I think try and be a bit flexible when assigning projects. I know the educational supervision forms can seem a bit rigid, like there's a box that says audit, and some people interpret that as this trainee needs to complete an audit in this department in this 6 months and finish it, irrespective of what they've got on their CV already, how many audits they've done in the past, what national project they're involved in. I think we can probably afford to be a bit flexible about this and actually think about what's helpful for the trainee and also what the trainee can offer. Often with academic commitments, your clinical time is less than full time, and quite a few people just put in a plea to say, please don't make it proportional to our time. So if you're in charge of organising 5 different things and have huge responsibilities on the clinical side, it leaves very little time. It's very helpful if educational supervisors can advocate for the trainee. There are lots of examples, as I said, where it's difficult to get study leave or you're not able to take up an academic opportunity because it clashes with something else. I understand that it's not always possible to provide trainees with that support, but where possible, if you could advocate for us. The protected research time, a couple of people commented on this and the fact that clinical responsibilities tend to bleed into that. One academic trainee I talked to said, you know, I'm viewed as someone who's just there 2 days a week and doing nothing the rest of the time. But in fact, I'm there 2 days a week and then I'm doing my academic work. Another trainee said, I'd appreciate it being treated like I have caring responsibilities. My academic time is mandatory. It's something I have to make time for. It can't be just eaten into by the clinical work. Just some tips for supervising all trainees, so whether they be academic or not. I think finding out about career aspirations, including what their life looks like. I remember a colleague of mine, not academic, said that her ST2 supervisor was the first person who said to her, you know, where do you think you're going in the rest of your career? And what do you need to support that? And that ended up with her signing up for a master's part-time because she just realised she wanted something extra on her CV. She wanted to enhance her learning. And he was the first person who'd really taken an interest in that. I think trainee career aspirations, oh yeah, it links on to the third point, but essentially any project you do within the department, so even if that's doing a QI project or an audit, there might be an opportunity to do that in the area of the trainee's interests, whether that's academic or non-academic, so that over time they're building up a portfolio that makes a bit of sense and has specialty focus. And every project can help shape a career. I know we all talk a lot about competency-based rather than time-based approaches, but clinical lecturers, as I understand it, historically sort of missed out on clinical time, relatively speaking. So they really needed to take this competency-based approach. And one of the trainees I spoke to said that she really valued when the educational supervisor tried to find out how to focus and guide her training rather than just talking about how many months or years you'd spent in whatever specialty. I hope this isn't too much to ask. I think as consultants, finding out what academic opportunities there are and encouraging trainees. I think don't be put off by really rigid requirements or intimidatingly high standards. I don't think they are always the case, and I think often the advertising can give a bit of the wrong message. If you just finding out when, for example, the deadline is for the ACF applications at SHO level, I think ACLs are a bit harder because they're a little bit less predictable. But as I said, finding out the deadline for the RCPCH conference, this kind of thing. I think we can all make use of expertise within our department. You might have someone who's actually done a PhD and 3 postdocs and they're working at SHO level, making opportunities for any academic trainees in the department to present their work early on. They might have the skill set to facilitate journal club and to lead teaching. And either way, just to share their findings so that other trainees in the department can benefit from that. And as I talked about, I think the term research can be much broader than we think. Okay, I hope I've made the point that research in children is important and it is ethical and we need to be doing more of it. But having said that, research doesn't need to look like the conventional understanding of the word. And what it should certainly include is advocacy, patient and public involvement. I think we can all help as trainees, as educational supervisors. We can promote the academic components of the training pathway, and we can support our trainees in whatever pathway they're on. That brings me to the end of my talk.
So, as it says, Helen Stewart, so I'm a PEDS emergency consultant at Sheffield Children's. I also do some critical care transport in the Northwest. Now, to most people, that probably doesn't scream health promotion. So it's been a bit of a journey for me. So what is health promotion? So this is one definition: enabling children, young people and families to increase control over and improve their health. So it's quite a new addition to the curriculum. I didn't really have to think about it as part of my training. I obviously did PEM Grid, and it was actually bizarrely that led me to an interest in public health and health promotion. When I started expressing this as a public health, as an emergency physician, I got some very funny looks. It seemed a very odd combo for people that I was working with. But for the first time, I was seeing patients that were from an unfiltered population. As a PEDS trainee, most of your acute patients come either via the GP or via the emergency department. So they've been through a bit of a filter, but I was just seeing everyone who just rocked up. And I started to realise that a high proportion of my patients were from the more deprived areas of the city. And I didn't really understand why that would be. And I've been very guilty in the past of the eat less, stop smoking, very simplistic attitude to health. But then why would that be linked to deprivation? So I did a little bit of reading and started looking into it. I also was quite clear that a lot of these presentations were in some way preventable. Asthmatics who could be managed better. And I really, very selfishly, how can I prevent children coming to this busy emergency department? So, and importantly as well, it's not just about that. Actually, what we know is that children, young people want more health promotion as well. So RCPCH and us have done some work on this. They want more health promotion advice. They want it to be interactive. They want it to be memorable. They want to know how to maintain good mental health. And they also want more links with people who have lived experience, just help them manage their conditions. They want more time and more support about buying and cooking healthy food. A lot of the feedback that RCPCH and us get about, particularly things around obesity, is they don't really think that we care, because no one asks them once they go to secondary school. It's all at primary school, when actually it's at secondary school that they have a lot more autonomy over what they're eating. So they actually don't think that we're that interested. But they do want the information. They want better health education. Ultimately, we all want to see healthier children that have the capacity to achieve their full potential. And as healthcare professionals, we have a really unique opportunity to contribute to achieving that aim. We're a respected voice. We regularly come into contact with disadvantaged families, and we can make that contact count. It's not just about the patient, but you've got the whole family there who've got siblings and other issues they may be needing to deal with. So how can we and trainees use that contact to improve the health of children and their families' well-being? So I wanted to go over initially just some of the kind of basic concepts that I think everyone needs to be familiar with to take any of this work forward in their clinical lives. So what makes children unwell other than viruses and bacteria and falling off a trampoline? And where are opportunities to intervene? Some of this you may be familiar with, and I'm sorry, but I think they're kind of some basic principles that it's important everyone understands. And also links a lot to the key capabilities within the curriculum. So a lot of this is the stuff that I was kind of learning and absorbing as I started becoming interested in this. And I do think it made me a more compassionate doctor, really putting into context the presentations. So depressingly, health services account for about 20% of health. The rest is outside of the health system. So behaviours 30%, socioeconomic circumstances are huge. That's 40% of your health outcomes, and your built environment is about 10%. So you may have seen this diagram before. It's from Dahlgreen and Whitehead, and it just goes up through the levels. So in the middle, age, sex, hereditary factors. There's nothing that we can do about those. That's inbuilt at birth. Then you've got your individual lifestyle factors. So these are things like smoking, alcohol, nutrition. And then we've got social and community networks. So where are you living? What kind of support have you got around you? We know that loneliness leads to ill health. And then the wider, you could say more political things. So your work environment, living conditions, housing. Are you living in a damp house? Are you living in a cold house? Water and sanitation. Do you have fluoridated water? Do you have dignity in your work? And then finally, you've got those wider general social factors. So race, ethnicity, gender, those kind of systemic racism, systemic misogyny, those things that can influence health from a wider community perspective. And it's a combination of these things that are impacting different populations, and that results in inequalities in health. I'm sure everyone's heard of health inequalities. It's been a huge thing since COVID. It's really brought it to light. But they are avoidable, unfair, and systematic differences in health between different groups of people. So I actually found this image really powerful the first time I saw it. It shows the difference between equality and equity. And I think historically we've been guilty of being on the equality side. We're fortunate we have the NHS and it's free at the point of use. And so we think that means everyone gets equal access to healthcare. But with a little bit of deeper digging, do we? We know that people living in more deprived areas have less GPs per capita. So they have less access to a GP, the people that probably need it most with more complex chronic health conditions. So we can see that actually what we put in, if we put in equally, that's not going to get equal outcomes. And actually different groups do different levels of input to get the same outcome. A huge part of it is poverty. It's one of the biggest factors in determining health. So we know that 3.9 million children live in poverty in the UK. That's 27%, which seems huge. 8 in a class of 30. Now, obviously, that won't be every class. Some schools are in more affluent areas, and some classes will have a much higher proportion. 49% of children are those children in lone parent families. 46% of children in Black and minority ethnic groups are deprived. And 75% of children in poverty are actually in a working household. So it can dispel these myths about people not working, people choosing to be on benefits. It's just not true. A huge number of children in poverty are in a working household, but wages are just not sufficient to allow them to live a full life. So a lot of this data is from the Child Poverty Action Group. And we know that between 1998 and 2003, child poverty was a government priority, and it fell by 600,000 children. So it's not an unsolvable problem. It is possible to do something about it. And we know the health impacts of poverty: high mortality rates, obesity, poor respiratory health, poorer outcomes for long-term conditions, dental health and mental health, which is obviously a huge problem at the moment. It's got an impact on all areas of your life, on your education, on your nutrition, on housing, on access to health services. And hospitals are just as important in that. Attending an outpatient appointment, I don't know if anyone's seen this work by Ian Sinner in Liverpool, but attending an outpatient appointment on average costs £35. So 23% on universal credit can't afford to travel to essential appointments. Inpatient stays are expensive. They've got parking problems, they've got food to buy. They might have to stay in a hotel nearby if their child is staying for a long period of time. And a lot of families, particularly as we go into this winter, they just can't afford it. And actually, as a health organisation, in some cases, we're actually making these problems worse. So obviously my background is emergency medicine, and as I said, it seemed to me that I was seeing more patients from the deprived areas of the city. Look at the data, and that's true. Data is really powerful in health promotion activities. It's a really useful lever, and it really directs any activities that you might want to do. So when we looked at our data, you can see that actually, on the left in the first graph, you've got the most deprived 20%, and then the least deprived 80%. So you can see that actually, generally, we're actually not too bad in Sheffield compared to the rest of the country, but generally 50% of ED attendances are coming from the more deprived, the lowest 20% deprived sections of society. So that does reflect what I felt that I was seeing. But also when we looked at our triage categories, you can see that there's more primary care triage. So it fits with the inverse care law. We know that there are less GPs per capita in the poorer areas, so it makes sense that we're seeing more primary care triage patients in the department from those groups. But there's other concerns, there's other reasons why they might choose to attend the emergency department. They might not be able to miss work for a GP appointment. Also, some families are unfortunately living very chaotic lives, and it's the only way they can access healthcare. We know that the Nuffield Trust released a report a few years ago. The most deprived are 58% more likely to attend ED than the least, 55% more likely to have an unplanned hospital admission. And if they're in children with asthma, those in the poorest 20% have 2.5 times the chance of an emergency admission, which was an increase on 10 years prior to that. It was only 2 times. So there were inequalities in my local population. The same inequalities will exist in your local populations, the populations that these trainees are seeing. And I wanted to do something about it. But as a trainee, I found it really hard to know what to do. When I asked people looked at me like, why are you caring? You're an emergency department person. And no one really had any practical tips. There was a lot of information, and there's more and more information over the last few years about the impact of poverty, about inequalities, but not a lot of advice on how to do something about it. But it is becoming more widely recognised, and actually there are some ideas out there. The other thing I think it's important to be aware of, and it puts some of our health promotion activities in context, is that actually they need to deal with some of these things before they can actually take any advice. If you just tell someone to stop smoking, but actually they can't heat their home or they can't feed their kids, they haven't got the mental capacity to think about stopping smoking or to eat more healthily. They need to, if they can only afford the unhealthy food, then that's what they're going to buy. It's not that they don't know it's not healthy, but they've just got no options. So we need to focus on making sure people have these basic levels of need met before they can start moving up and thinking about their general health and their mental well-being. So poverty is pervasive, it's a key determinant of health, and it takes over our lives. And it explains why a lot of families cannot listen to the health promotion advice we might have been giving them. Another thing I think it's really important for paediatricians to be aware of is adverse childhood experiences. So they also contribute to health inequalities. You may have heard of them. As a paediatrician, I hadn't heard about them about 4 years ago. I think there's much more widely publicised now. It's a slightly problematic term, but I think it's quite useful to demonstrate the point. So it came out of a study done in the 90s, where they picked 10 potential causes of childhood trauma. So you can see them here: domestic violence, substance abuse, mental illness, parental separation, divorce, an incarcerated parent, levels of abuse and levels of neglect. And then they looked at how if people had experienced these. So 67% of participants in the study, and they came from all sections of society, had experienced at least one. And then they picked 4 as kind of a cutoff. And saw that 12.6% had experienced 4 or more. And those people had, as you can see there, 3 times the level of lung disease and adult smoking, 11 times the level of intravenous drug abuse, 14 times the number of suicide attempts. Wide range of different health impacts that they were more at risk of. There was a modified study in a paediatric population which showed 2 to 4 times increase in rates of behaviour problems and developmental delay, 5 times the rates of injuries, and that just wasn't just about NAI, that was about supervision and capabilities within the home. And lower BMI, actually, they had an increased risk of, but we know that a lower BMI in childhood can lead to obesity later in life. So I think one of the reservations about this study is that there's a tendency to think these 10 things are the cause of childhood trauma, and that is not the case. The purpose of using this is to show that actually any childhood trauma can have a health impact, and actually a lot of those health risks remained even after the behaviour was accounted for, the smoking and the drinking. So there is some epigenetic changes going on which result in worse health later in life. And that can be from any cause of childhood trauma that isn't necessarily mentioned in this study. So this is the health promotion. This is health promotion advice that you can see on the left, the top 10 tips for better health from the 1990s from the Chief Medical Officer. And things that we've all traditionally been doing: smoking, eating well, exercise, manage your stress, drink in moderation, sun protection, safer sex, cancer screening, the highway code, and learning ABC. So someone, David Gordon in 2015, put a slightly tongue-in-cheek health promotion advice, but actually these things will probably make more impact on general health than will the original top 10 tips. So don't be poor, try not to be poor for too long, don't live in a deprived area, don't be disabled or have a disabled child, don't work in a stressful low-paid manual job, don't live in damp low-quality housing or be homeless, be able to afford social activities and annual holidays, don't be a lone parent, claim all the benefits to which you're entitled, be able to afford a car, and use education as an opportunity to improve your socioeconomic position. So, like I say, slightly tongue-in-cheek, but they are generally things that people can't do very much about, but they have a huge impact on health. And so we need to think about ways that we can start to ameliorate, I can't say that word, try and reduce some of the impacts of these. And so what can trainees do? It all seems, for a long time, I found it all very depressing. There's all this information, we know all this, all these things that impact health, but what can I actually do? And quite often it didn't seem there's very much we could do, but I think actually that's changing. So I've used the current curriculum, but it does map, the new progress curriculum for next year is actually very, very similar competencies and objectives, so it will map onto that. Anything we talk about here will map onto that as well. So the level 1 trainees, I think at this stage there's still an important role for kind of the basic healthy living advice. So giving advice from the early years to adulthood is the key objective. Understanding the factors which contribute to child health inequalities and the consequences of those inequalities for disability life expectancy, understand the effects of the environment and their social contexts, and understand the factors involved in global health. And for junior trainees, I think this emphasis, it's just about making every contact count, having a basic understanding of the mechanisms of health inequalities, all those information that we have, that I've just given you, those kind of things I think are just the basics to put everything into context. But the main role of trainees is that they are patients. It's a huge part of their job, and that is a contact with that family. And we routinely ask a number of questions that will offer opportunities for health promotion. So we ask about vaccinations. That's the most obvious one. That's a big focus for the Health Improvement Committee at the moment, because we know that during COVID vaccination rates fell. So that's an opportunity to have a conversation with the family. They're also likely to have been weighed, and we usually ask about smokers at home. So there's an opportunity to discuss weight, it's an opportunity to discuss the impact of passive smoking, explore parental concerns about vaccinations, and these can all be evidenced with CBDs, reflections. Also, their presentation may present an opportunity. So whether you're wearing a seatbelt, safe sleeping, accident prevention, does their trampoline have a net around it? Do they wear a helmet when they're out on their bike because they've had a head injury? Have they actually got hold of the Calpol bottle and taken too much? So safe medicine storage. That is all health promotion. That is all giving the family information that can potentially help to prevent them having to come back to hospital in the future. A nice little mantra is this ask, advise, act. So ask, so we're asking them, we're clerking them in, we're asking them. We can ask a little bit more about their beliefs, about their understandings, but we're getting the information. Then we need to advise them, so we can give the information. What are the benefits of vaccinations? What are the potential complications of passive smoking? What's the potential complications of obesity? Give them some advice, and then act. So point them in the direction of resources, of services that could help them, give in smoking cessation services or weight management programs, dietitian potentially, whatever's available. I think it's really important that that act part is in there. We really need to make sure that we don't just have the conversation and then do nothing about it, because that can actually do more harm than good. It just gives the impression of box ticking without a genuine desire to help, as we mentioned with the obesity and the young people as they get into teenage years. So, I mean, it's easier said than done. They can be difficult conversations to have, and they can come up with some resistance, but we do know that there is evidence for those short, sharp interventions, that they actually do have some impact. And the individuals, the trainees' approach to that conversation will be significantly influenced by how they understand the context that the family are in. So understanding the impact of ACEs, understanding the impact of poverty, understanding that these are not families that have deliberately made their child overweight, that they are potentially are worried about it, but they don't feel that they have any options. So it's about having that conversation in a supportive manner. But there are lots of opportunities there where the trainees can do short, sharp interventions that may make a difference in the long run. And there are resources to help them with that. So RCPCH have e-learning. There's a vaccines in practice one, which actually has some really helpful tips on how to have those conversations and on how to break the information down to give to them. There's the Health Inequalities Toolkit, which has been launched quite recently by the college, and part of that is also about having difficult conversations about family circumstances. There's the How to Manage programs like obesity. There's actually the health promotion resources page on the college website in the education training section. There's a lot of this information is in there, and there's examples in there as well of things they can do. And there's an e-learning for health program on health inequalities as well. They're all things that can just help to resources to learn about these things and to help them manage some of these things in practice. Global health is another one of the parts, one of the competencies. There's healthy vision for children and young people across the world is one of the RCPCH statements. And there are ways that you can consider global health from, again, through the admissions process, through the clerking process, the child with a fever, have they been somewhere that might change the spectrum of potential infectious diseases? In a neonatal check, does this child need a TB immunisation because of their background? There are lots of ways, that just little things that we can pick up that actually show that the trainee that is thinking about the global impact on this individual child's health. So moving on to level 2, I think this stage you're really just trying to build on that knowledge gained in level 1. But more actively identifying potential for vulnerability. Is this child a refugee? Are they a looked after child? Actively screening for mental health problems and offering support where needed, and tailoring the advice to the family's specific cultural needs. It's just about taking a slightly wider, more holistic approach to each and every patient, and again documenting through CBDs, that reflections, that kind of thing, I think can really show what the trainee is achieving with their consultations. And consider external agencies as well, third sector. So not just thinking about what's available in the hospital, but actually what else is available. There's a child presenting with a mental health problem, they can be directed to Mind and Cooth. Mind actually have a lot of leaflets for parents as well. So considering the wider impact on the family, there are leaflets for parents of children who've self-harmed, which can just help them. It's incredibly scary, it's difficult for parents, and considering the impact of the child's presentation on the whole family and offering them written information to help can really make a difference. So as it says, we're taking into account the potential impact of this cultural, social, religious, economic factors on the child and family health, interacts effectively with the children, young people and their families. They're using translators, making sure that they've got written information in the right language. They're applying the knowledge of how cultural, social, religious, environmental and economic factors impact the child and family health, and applies knowledge of the health system to promote child physical and mental health and disease prevention. So like I said, just finding the right services, knowing what's available locally. Level 3, demonstrating leadership in the promotion of health and wellbeing practices in the wider community. Demonstrates understanding of the systems that enable clinicians to analyse data relating to the patients under their care, applies health information data to a wider community, evaluates the way that patients and families use the health system. So this is more about leadership, as it says. This is your kind of ST6 to 5, 6, 7, 8 leadership. That could be demonstrating behaviour. Yourself, cycling into work is one of the examples used on the college website, advocating for change, and I think it's also about thinking about potential for audits, guidelines that may help to demonstrate competency in this area. So how many attendees are overweight or obese, looking at your local data, trying to understand the problem a little bit better, doing some teaching on it, maybe coming up with a guideline or a leaflet that can be given out to children with mental health problems, with some resources and local signposting. So there's quite a few different approaches that I think that just show that slightly deeper understanding, understanding the context a little bit more, and thinking about what they can personally do to help these families. And quality improvement, I think, is a big part of that. The toolkit, as I mentioned, that's got a few suggestions for quality improvement. And there's also some advocacy in there, which can be another way to demonstrate leadership. There's things that you can template letters to write to your MP. It's keeping an eye out for kind of current campaigns. So today we got the launch of the Feed campaign, which is looking for the government to support the extension of free school meals to all children on ideally all school children, but the first instance, all school children on universal credit. We know that so that can be supported. There's also the I can never remember what this stands for, the Wellbeing, Health and Action Movement. the One Project, which is a group of paediatricians, and they have a heat map with a number of different quality improvement project ideas. We actually took one of theirs locally, which was a leaflet on resources for struggling families, where we can help them increase their income, increase their community participation, increase their well-being, particularly relevant as we move forward into this winter with the cost of living crisis. And we've also locally introduced travel vouchers. Now that's a trust-wide project, and obviously it's not something that potentially trainees, but it's something they could advocate for. And there are other smaller QI projects that they could do that would demonstrate these health promotion competencies. So I thought we'd just talk through a little case study just to show just to demonstrate some of those examples. So obesity, it's an ongoing concern for everybody. It's not new, but we know that it's got worse in COVID, particularly as you can see amongst the deprived children. So on the left, you've got this COVID. This is actually pre-COVID, this graph, and you can see that actually in the least deprived children, obesity had fallen slightly, but it had consistently gone up in the most deprived, and that gap has widened significantly over that 10-year period. But we know that during COVID it's got worse, and you can see on the right the National Child Measurement Programme showed that actually over COVID obesity had increased significantly, and that is mainly in the more deprived groups of society. Why might that be? Healthy food's cheaper, it's often harder to access. You know, if you don't have a car, getting to those big out of town shopping centres is difficult. Mental health is important, and if your mental health isn't right, I mean, I know I've tried to lose weight before, and if my mental health is right, it's not possible. More dense housing, less green spaces, less safe neighbourhoods, outdoor play is harder. After school activities, they're really expensive. So there's multiple complex reasons why children from deprived areas are more likely to be overweight and obese than children from the less deprived areas. So we've got a case example. We've got a patient who's 10, referred from the emergency department because they have had an asthma attack and they're unable to space his inhalers. The ST2 is clerking them and notes they're 50 kilos. This is well above the 95th percentile and makes them in the obese category, but the family are very anxious about their child's breathing. So where are the opportunities for health promotion in this situation? So I think the first thing to consider is timing. Is now the right time? This is an anxious family, they've got a respiratory problem, possibly not, but they can go back later when the child's better in the morning ward round, some opportunity in the future. And they can do a short intervention about obesity using the AAA approach. So ask about weight. Do they have any concerns about it? Have they noticed it before? Has it been an issue? Advise them it's probably affecting his asthma. And signpost to resources. Consider the dietitian input. Know what is available locally. Notify the GP as well, because the GP may not necessarily have seen this child recently. They may not know that they're obese. So actually making sure that their GP knows that they can potentially look at some interventions next time they see them could be really helpful. But there's other opportunities here as well. Checking the inhaler technique, making sure they've got a written asthma plan, follow up with the asthma nurse. These are all ways to empower that family to better look after this child's health, and can all be evidenced by CBD's, mini KEXs, DOPS for inhaler technique, reflections on the conversations. Level 2, as you get more senior, you might start to consider the economic circumstances of the family. The whole family are overweight. Mums mention they struggle to afford healthy food. So look at can you signpost to free activities, social, kind of a social prescribing approach really, you know, park run, things like that. Signpost them to citizen advice if they're struggling with income, just exploring the wider family circumstances. And actually the Health Inequalities Toolkit, the conversation advice in there is about how to talk about poverty, because it is quite delicate and there are some families that might not want to discuss it. They might feel embarrassed. Have they checked that the environment is right? They might not want other people hearing that conversation. And also they might also start to consider the impact of obesity on the child's mental health. Are they being bullied at school? How do they feel about their weight? Do actually they need a little bit of support, someone to talk to, a youth worker or something like that? And making sure that all the written information is in the appropriate language. And then level 3, I mean, this is what happened for me. You know, it's not the first child to see that they've been obese that day. They could do a quality improvement project, check the BMI of all attendances, create a signposting resource to be given out so that the information's there for everybody to give out easily. So I think there are, in each interaction, there are a number of opportunities where people can just give a little bit of information and promote health to that family. There's a whole number of different resources out there. Just picked a few. On the health promotion resources on the college website, there's HE Embedding Public Health into Paediatric Training. That's a really comprehensive, really useful guide. There's a couple of journal articles there, a course run by Mitch Blair and Imperial. E-learning for health, again, they have that Making Every Contact Count. I don't think that's paediatric specific, but there are some useful things in there. There's the Core 20+5. That's going to be a useful lever advocating locally. At the moment, it's adults, but they are working on a children and young people version, and that's about the NHS England focus on health inequalities going forward, with the Core 20 being the most deprived sections of society, plus is the other communities that might not necessarily fit into that but have disadvantages, such as refugees, coastal communities, and then 5 is 5 key areas to work on, which in the adult version is like hypertension, maternal health, but there will be a children and young person version coming out soon, so that's something to look out for. There's the PCH course on child health in low income settings from the global health perspective, and then there's looking for data, local data to help you direct your activities. So Child Poverty Action Fingertips, which was run by Public Health England, it's now run by the Office of whatever the new one is. And then the Zero Suicide Alliance. They have suicide awareness training, which is only 20 minutes, and it's really useful. Really makes you feel a lot more comfortable just having those difficult conversations about mental health.